First of all, I just want to say thank you so much for inviting me to speak with you all. And I'm just so, I don't know, moved to see so many people across the country. I really am feeling a sense of community and connection from coast to coast, really just hearing all of the great work and all of the people that are taking the time out of their day to think about the patients that we see, the kids that we see, and to really think about how their experience has shaped them and how that we can provide the best care for them. And so thank you so much for the invitation to be here. And I'm really excited to share some information with you today. So without further ado, let's review our training objectives that you all may be familiar with from the registration. So today we will review typical brain organization and childhood development. And then once we establish kind of what typically should happen, then we'll talk about how does trauma affect the development of the brain. And then we'll also, we'll talk about how it affects the brain, but then also how those changes in the brain can influence the psychological, developmental, and neurological impacts when patients or when kids, I say patients a lot because that's normally how I'm talking about young people. So forgive me if you typically use clients or children or adolescents or young people. I may say patients because this is sort of what I'm used to saying, but I know that you all know who I'm speaking about. And but when kids experience neglect and abuse when they're young, how does that change their developmental trajectory? And then I'd like to talk about some tools that are available for understanding traumatized young people, and then also to talk about how do we provide better trauma-informed treatment for such kids, and then how do we provide healing, and how can the power of relationships and community build in healing for these patients and kids. So, and hopefully that will set the stage for a training that you'll have later in the year, and we'll get you excited about that. But before we move into the objectives, I would like for you to think about this question. And I know that many of you did your homework and watched the first impressions video. So you may already, this may be an easy question for you, but I'd still would like you to think about two different children. You're meeting both children at around age 12, and they're presenting for treatment. And I want you to think about which child is more likely to have better outcomes. So we have child A, who from age 0 to 18 months was in a very nurturing and loving environment, had their needs met in a consistent way. And then something happened, and they are now from age 18 months to age 12 in a chaotic or neglectful and abusive environment. And then we have child B, who for the first 18 months of life was in a chaotic, neglectful, and abusive environment, perhaps presented to Child Protective Services, is now in a new environment from age 18 months to age 12. And during that time was in a nurturing environment. And so I want you to think about which child, both children are going to have challenges, which child is more likely to have better outcomes with treatment. And if we were in person, I'd have you raise your hand to know how much time I need to spend teaching you guys, or maybe you already know everything, but kind of hold in your mind, do you think child A or child B is more likely to have better outcomes? All right, so I know for me, if I'm going to learn something new, I need to link it to something that I really care about and something that's personal. And for me, that's the kids that I take care of every day. And so I'm going to share a case. A lot of the details have been changed, but this is a patient that I provided treatment for. So, and this picture, by the way, is just a stock image from PowerPoint. This is not a patient, but I wanted you to have a picture of a child that we can think of throughout the talk and kind of reference. So Kate is a 7.5-year-old with a previous diagnosis of bipolar disorder and reactive attachment disorder who has been having episodes of emotional dysregulation, including tantrums at school, running away at school, cutting her arms and her face with a razor. She's sneaking food and hiding other belongings at home and at school. She has sleeping problems, including falling and staying asleep, and she's often found throughout her house and sleeping on the floor in various rooms, but when she is supposed to be in her room at nighttime, she cannot fall asleep. And she also has separation anxiety when she is away from her primary caregiver. And even though she's only 7.5 years old, has had multiple school suspensions as a result of her behavior. And my guess is that this story is not very shocking to most of you, that you have worked with many kids with similar stories. All right, so what else do we need to know about her? So her mother, unfortunately, was using methamphetamines and THC during pregnancy. Her father suicided during when her mother was 6 months pregnant with her. She was removed at birth as she tested positive for both methamphetamines and THC, and was placed with her maternal grandfather and his wife, who were caring and attuned providers. And then she was returned to mom at age 6 weeks, as mom was in a treatment facility and was doing well at that time. Unfortunately, when mom left the treatment facility, she returned to using drugs, and Kay was again exposed to a chaotic living environment, which included domestic violence exposure, neglect, and likely physical and sexual abuse. And at age 18 months, she was removed from mom's care and placed in the care of her maternal grandfather and his wife, who adopted her. And so, from my perspective, this is a kid that we'd have sort of standard treatment for. She would get referred to psychiatry, so comes to see me, and then unfortunately, you can see with kind of typical treatment, my toolbox is pretty limited. So if kids are coming to see me, it most likely means that someone thought, this patient's symptoms are beyond what can be controlled with just therapy. Perhaps they need a medication. So I look in my toolbox and I say, okay, well, she has impulsivity. Maybe I need to start a stimulant. She has a lot of mood swings. Maybe I need to start a mood stabilizer or an antipsychotic medication for her aggressive outbursts. Maybe I need to start a medication for sleep. And then, of course, I want to keep her in therapy, which traditionally therapy for most of the kids that I work with is about 50 minutes per week with, a single individual. And so, when I left fellowship, this is what I had in my toolbox. And in my mind, first of all, I'm not going to start all these medications at once. I'm actually a pretty conservative prescriber when it comes to medication with children. I think that they're a tool, but I don't think that they're the answer for these very complex symptoms, right? And so when I left fellowship, I felt a little bit inadequate. I look at my toolbox and I just see a lot of medications and maybe some therapy, but do I really think that this is going to be enough for this kid who has had all of these early adverse experiences? And so this sort of prompted me when I had finished fellowship and moved to Austin. I had been thinking a lot about, is there another way to think about these children? And I had the good fortune at that time, I was working at the Center for Child Protection. And the center there at that time was becoming certified in something called the neurosequential model of therapeutics. And this model was developed by Dr. Bruce Perry, who you saw him in the First Impressions video. He's interviewed throughout that video. And he is an MD, PhD, and is just a phenomenal human and world-renowned. He doesn't like when I say world-renowned, but it's true, specialist in trauma. And he has been a mentor to me, and I have completed the phase 1 training in the neurosequential model of therapeutics, and I'm currently in the phase 2 training. And our fellowship is actually the first training program for child psychiatrists, where the training is incorporated into our fellowship program. And I'm very excited about that. I hope that our fellows, when they leave training, that they look in their toolbox and see some extra tools that just weren't available at the time I finished fellowship. I had a great training. I'm very thankful for that. And there's been new tools that have been developed since I finished training, and I'm putting them in the toolbox of our trainees here with the guidance of Dr. Perry. And so I do, if this is something you're interested in, I'd like for you to, I'll show you how to direct you to the Child Trauma Academy to learn more about the neurosequential model. And also, if you're looking for kind of you're not wanting to do the training, but you want to hear more about some of the concepts I talk about today, one of his most popular books called The Boy Who Was Raised as a Dog was sort of my gateway into learning about all of the models that I'll talk to you about. And it's a great read. I encourage you to consider reading it. And then also to note, if you see a slide that has this emblem in the bottom right-hand corner called the neurosequential, or saying the neurosequential network, that is one of Dr. Perry's slides that he gave me permission to use today. All right, so going back to the question, is there another way to think about these children? I found myself wondering, could we change the question from what's wrong with you to what happened to you? That oftentimes, especially as a psychiatrist, I'm sort of encouraged to, what's the diagnosis? What's the label for this patient? Do I really need to take a step back and say, what happened to you that is causing all of these symptoms? And I've been giving similar talks like this, and I've had the slide changing the question, and then was talking with Dr. Perry and came to discover he is releasing a book with that same title, What Happened to You? And I'm sure I have this question from the training. And his book is actually coming out next week. And so I encourage you, it's a book with Oprah Winfrey, and hopefully we'll get a lot of great positive attention, as she's a very influential person, so that more people throughout the world and country can know some of the concepts that I'll share with you today. And also just to talk a little bit about what is the neurosequential model of therapeutics. It is a neuroscience informed and developmentally sensitive approach to the clinical problem solving process. It's not a therapy, it's not a treatment. It's very inclusive of all of the other therapeutic modalities that are out there. But what it does help you do is assess the person that you're working with in a trauma-informed way and a developmentally sensitive way, so that perhaps you may make the same recommendations you otherwise would, or perhaps you may make different decisions about when you provide certain treatments. And we'll talk more about that. But just to say that, don't be alarmed that NMT is not going to take anything out of your toolbox that you already have, but it may help you know, do I use the hammer first or do I use the screwdriver first? I'm not sure why I went with the toolbox thing. I don't know too much about tools, but I'm quite sure that if you're building something, there's an order in which you build things. And similarly, when you're picking what type of therapeutic intervention to use, perhaps there's a good order in which to select the different therapeutic interventions. And NMT offers you that. All right, having said all of that, let's get to what you're expecting to learn today. And first start off with the overview of typical brain development and organization in childhood. And so I'm going to spend a little bit of time on this slide, so don't get panicked if I'm spending some time here. I will not spend this much time on every slide, but this is really important for you to understand how our brains develop before we can talk about what happens when perhaps the development was interrupted by trauma. So on the left here, we have a picture of a brain that you're familiar with. And on the right here, we have an upside down triangle. And I hope to convince you that this also is a model of the brain, right? On the left is a model that we're used to seeing. It looks a lot more like what our brain looks like in real life. But in my mind, a triangle is a much simpler shape that I am familiar with and can build new concepts onto the shape that I'm familiar with. So we start off looking at the different parts of this triangle. We're going to break down our brain into 4 different regions. And so I'm going to start at the bottom because our brain matures from the bottom up. So when we're born, all of these structures exist. However, they mature at different stages depending on what age you are. So when you're born, this bottom part here, which represents the brainstem, which is the lower part of your brain, it's back here. If you touch right below the bones in the back of your skull here, where your head connects to your neck, your brainstem is right behind there. And your brainstem is kind of a highway that forms communication from your brain down to the rest of your body. So, okay, I'm thinking, Megan, go ahead and advance your slide and press the button. My brain is sending information down through my brainstem down to my hand to make that move. And then also information from my environment. So if I'm touching the stove, my hand has some sensory information that comes in that goes all the way back up. So my brainstem is really important because it's the highway between my central nervous system and my peripheral nervous system. And that's the first part of our brain to mature. And then the next part, as you go up, you have your midbrain, or this fancy word called diencephalon. I like to use the word midbrain. And its job, and you can see out here to the right, it gives a list of kind of what each area is responsible for. So your midbrain really helps a lot with rhythm. So when should I be awake? When should I be asleep? When should I be hungry? When should I be full? When should I, be in more of a state of alert, or be kind of winding down at the end of my day, ready to sleep? And one thing that I would like for, I'm going to pause here for a second because you're going to see me kind of gesture with my hand a lot. And I want to share with you something Dr. Perry shares with people going through the training, is that something you may not know, and you can get excited, is that you are walking around with a model of the brain all day long. So if you can humor me, I can't see you, so I don't know if you're doing this, but I think it's more fun if you're in front of your computer to go ahead and make a thumbs down sign. And imagine that this part of your brain is your brainstem. The kind of fattier part of your thumb, just at the base of your thumb, is your midbrain. And then on the inside here, on the inside of your hand, is the limbic system. So that corresponds here with the green box, and then here with these structures. They're deep inside of your brain. These parts of your brain we have in common with even reptiles. So sometimes people will call this your reptilian brain. This part of our brain is really important because it keeps us alive and responds to threat. And so, but it's wrapped around. So if you close your hand around your finger, inside your limbic system is totally protected by the wrinkly part of your brain that we're used to seeing, called your cortex. And the cortex's job is to do all of the thinking and planning. And many of you, if you kind of touch the front of your forehead, you're familiar with the part of your brain that's just behind your hand called the prefrontal cortex. And the prefrontal cortex gets a lot of attention because it is really important in helping us inhibit our impulses. And so we talk a lot about underdeveloped prefrontal cortex, or your prefrontal cortex doesn't develop until you're much older, patients with ADHD not having a active prefrontal cortex. So we talk a lot about it. And it's very important when we're talking about response to threat. And I'll tell you why. Because our cortex actually, and particularly the planning parts of our brain, are shut down to some degree by our limbic system. So you'll see me do this a whole lot. So when we, so let's talk about what happens when you're threatened. You get the sensory information from the outside world. It goes up through your brainstem, goes up through your midbrain and to your limbic system. So let's say I put my hand on the stove, that information goes really quickly, because these are the faster parts of your brain, goes really quickly up to my limbic system goes bad, danger. And then it doesn't even go to my cortex. Actually, the limbic system sends signals back down to my hand to pull it away. And that's really important. We actually, and oftentimes, if you've had this happen before, you've touched something hot and then you look to see what it was. I'm not going, oh yeah, that's a stove, I think I'll remove my hand now. No, because by the time I think all of those things, my hand already is very damaged. And so it's really important, because our limbic system, one, doesn't even invite the cortex to think about dangerous things, but also it encourages the cortex to be quiet. Because by the time we have a thought, like let's say a lion is chasing you and you see the lion, you can hear the lion, perhaps you smell the lion. If you for 1 minute stop to think, oh man, if I run that way, you know, there's something dangerous over there, or should I run to this cave? Oh no, that has a lake. Like the lion just ate you, right? So if you're taking time to do all of that thinking, you are less likely to survive. Now, why am I telling you all this? Think about the young people that you've worked with who have trouble staying regulated, and that they have kind of, their brains have organized around constant threat in their environment, and adaptively have stayed tuned up. Because if they are constantly around lions, so to speak, or around threat, we actually want their brain to be really good at sensing threat. Their limbic system is constantly scanning for threat and also ready at any minute to shut down the thinking part of their brain. And why is this important? How many times are we working with a child that we say, okay, all right, Billy, next time when you're upset, what are you going to do? I'm going to take deep breaths. I'm going to go in the hall. I'm going to count to 10. Their cortex knows all these really awesome strategies for staying regulated. But then guess what happens when they sense a threat? You know, the teacher's yelling at them, Billy, where's your homework? I told you this again. Their limbic system hears threat, shuts down their cortex. They're not even able to access the plan that you came up with. And so we're going to talk about how do we keep limbic system from sending all these signals of threat downstream, and then also from shutting down your cortex and keeping the kids that you're working with from accessing the smart part of their brain. So there's two ways to stay regulated. One is top down. So cortex telling me, all right, you're giving a talk right now. You might be hungry because it's dinner time here on the East Coast. But, okay, limbic system, be quiet. Don't run out of the room and go to the refrigerator. You need to stay calm. So I'm using my cortex to regulate myself from top down. And then we also have ways from bottom up to stay regulated and to keep our limbic system from ever sensing the severity of the threat that it would otherwise perceive. All right, I promised I would spend a lot of time on this slide, and I didn't bring my promise. So take home points from this slide. 1, we develop from the bottom up. 2, there are 2 ways to stay regulated. One is top down. That's the one we traditionally think about. But then there is also ways to kind of help stay regulated by keeping the limbic system happy. And generally that's by talking to this part of the brain that really likes rhythm and repetition and predictability. And we'll talk more about that. All right. Just to talk a little bit more, if you're even more of a big picture person, these are the 4 parts of the brain that I talked about. Your cortex's job is to reason and reflect. Your limbic system is to relate, meaning, should I go closer to that? Is that something welcome, or is it threatening? Should I distance myself from it? Our midbrain's job is to help us stay regulated. And then again, we talked about our brainstem taking in sensory input from the outside world. And then also what I didn't mention is somatic input. So maybe is my stomach gurgling, that kind of thing. So information from within our bodies as well. And then sending that information up to our limbic system cortex to make sense of it. Now, if the bottom parts of our brain are not happy, meaning if we are not regulated, we cannot relate well to our environment, and we surely cannot reason and reflect. And so before I can even engage in any type of cognitive intervention, which is what we're typically used to doing, using words, I have to first help the person I'm working with be regulated. And we'll talk about our relational, managing their relational sensitivity. And then I can help to reason and reflect. Okay, so that was kind of typical brain organization. Now, let's talk about what happens when a kid is living in, let's say, a place where they are not getting their needs met. Their brain is going to be organized in a different way. Before I can get too much into that, I want to introduce a concept called state-dependent functioning. And I'm going to invite you back. So we all, when we're listening to something, we kind of zone out for a little bit, zone back in. So if you've zoned out, I invite you to pay attention to this slide because I'll reference it a lot and is one of the most important concepts in my mind that I've learned when working with patients who have been in a state of threat. So the way to read this table is you first look at the mental state down here. So let's say, I'm in a state of calm. It's a Saturday morning. The sun is shining. My alarm is deactivated. I don't need to wake up at any time. I have 2 young kids, so there's no such thing as turning off my alarm, but pretending, I'm fantasizing that this exists for some of you, hopefully. And so I'm waking up on a sunny Saturday morning. I'm looking around my room and I'm thinking abstractly. I'm looking at my curtains and saying, oh man, those are kind of ugly. I don't know why I bought those. Maybe I'll look on World Market and see if they have a sale or whatever. I'm using the smartest parts of my brain. I'm using my neocortex and subcortex. And this part of my brain is able to reflect and think abstractly. Now let's pretend it's not a weekend and it's a weekday and my alarm normally goes off. I just don't hear it, but I've already hit snooze 20 times and now I am late. I'm not thinking about my curtains. I'm thinking, all right, Megan, get your contacts in, brush your teeth. Did you bring your computer to work? Get out the car, make sure the kids are fed, I'm sort of in this concrete way of thinking. My cortex is still working. I'm still able to plan, which, the prefrontal cortex likes to do. But also I need my limbic system to be activated, right? I need this sort of feeling. It's not exactly threat, but some inertia that, there's maybe a little threat. Your boss is going to be mad at you if you don't get to work, right? Now let's pretend on my way to work, I have a small fender bender and now instead of being in a state of alert, I'm in a state of alarm. And this actually happened to me in residency. I rear-ended the person in front of me, and I jump out of the car and say the goofiest thing. I open the driver's side door of the person that I rear-ended, and I recognize the person. He's one of my colleagues in residency. And instead of like, are you okay? What do I say? I go, what are you doing here? And I'm like, and I've reflected back on that so many times and thinking that was such a goofy thing to say. Why did I say that? Well, now I understand that at the time, I still have a cortex, it's still working, but it was sort of shut down a little bit, and my limbic system and midbrain were taking over at that point. And so I was not saying something very logical. And what's interesting is when I talked to my colleague later and said, man, buddy, I'm really sorry I asked you what you were doing there when I just hit your car. He didn't actually remember me even being there. And so what's interesting is he was probably in a state of fear or terror. And the primary brain area activated was his midbrain or brainstem. And he was probably reactive and reflexive. And that part of your brain does not store narrative memory. And so he was in a type of survival mode, if you will, and he actually just jumped right out of the car, and then later did remember me being there, but he did not remember that I was the first person to open his car. So why is this important for the kids that we work with? And not just the kids, but the families that we work with and each other, because if we're working with people in crisis situations, it's also dysregulating to us as well, that until we help people move back to the left on this continuum, we don't stand a chance to communicate with people using words, and we don't stand a chance for people to learn any concepts that we're trying to teach them. And we also don't stand a chance of getting helpful information. And so, and you've run into this before, when you're talking to people about traumatic events that happen, they don't remember things in a narrative way. And why? Because when you're in a state of threat, alarm, fear, terror, your cortex that normally is there to kind of make a movie out of your memories, it's not functioning optimally. It's not the primary brain area being used. And so we don't make memories, but we do remember our sensory experiences. Like I remember the smell of the brakes of the car. I remember the sound of the airbags deploying. I remember the horn going off. I remember someone shouting. That's because these lower parts of our brain are pros at listening to our sensory environment and sending that information up to our limbic system. And so that's what we remember. And unfortunately, a lot of times when we're trying to interview kids and ask them about traumatic things that happened to them, the legal system often really wants this kind of narrative package story. But if we understand this concept, we can advocate for the kids that there is a great reason that they don't remember this in a narrative way. It's not that they're faking it or making it up or anything like that. It's that the parts of their brain that remember things in a way that we can put into language was not active at that time because they were trying to survive, and their brain was working in a very adaptive way. All right. Other things to point out. So this is another similar state-dependent slide that I like, but if you look what happens to our functional IQ when we're in a state of fear versus a state of calm. And I bring this up because perhaps some of you may order testing for some of the kids that you work with. And I know I used to be the medical director for a residential unit where we did testing within the first 30 days that the kids were admitted. And their IQs always seemed so much lower than what I expected them to be. And if I really thought about it, or I have thought about it in hindsight, these kids were in a new environment. By the way, your limbic system is super keyed up when it's in a new environment, it should be, and had just left a crisis situation, and I'm trying to test them. And most of the tests are designed to assess your cortex, right? And their cortex, I already told you, was underactive at that time for good reasons. Like the kid was trying to survive. Okay, so this is sort of the science-y part of the talk. So if you love this, get excited. If you're like, maybe I need to take a mental break for a second, then perhaps now is your chance to do that. So, but I could not give a talk talking about the stress response system without going into this. So we have something called our Hpa axis, which is, the H is for hypothalamus, the P is for pituitary, the A is for our adrenal glands, which are found above our kidneys. And I will point out, here's where our hypothalamus and amygdala are located, here and here. Or I'm pointing out the amygdala because I like to, but that's not the A. Here's our hypothalamus. All right. So let's say we have, typically what happens, we have a stressor, our hypothalamus says, oh dear, that's not great. Let me release some CRH, which then communicates to our pituitary gland, which isn't pictured here, but it's a gland deep in our brain that then releases ACTH, which then goes and talks to our adrenal glands above our kidneys to release cortisol. And if you've talked about the stress response system or read about it, you probably heard about cortisol. And we're not going to talk a whole lot about it other than to know that cortisol modulates our stress response. And then when our stressor goes away, hypothalamus says, things are okay. All of these chemicals are stopping released. And then also cortisol tells the hypothalamus, you can stop releasing all these chemicals. There's enough cortisol in the blood to modulate the stress response. Stop sending me information, and the cortisol levels go back down. Now, what happens if the stressor stays around? Hypothalamus is getting lots of information that we're under threat, bad things are happening. Pituitary gland, same messages. So we have lots of cortisol being released. And there are lots and lots of studies looking at this, and the data is a little bit contradictory about whether cortisol levels stay high all of the time. But what we know is that this increase in the stress response activation system, or activation of the stress response system, results in change in gene expression in the stress response system. So we see chronic changes in how these kids respond to stress. And then also, this kind of inhibition that we typically have, we find is less effective the more this system is activated. And so our hypothalamus is kind of confused. Should I be releasing more cortisol, less cortisol? Should I turn off? Should I not? The threat is still here, but having cortisol for a long time isn't good for other reasons. And so this Hpa axis looks different in kids who have experienced chronic threat. It was not necessarily designed for the chronic threat that our kids experience. And then other parts of our brain, so if we go here, right, that you'll often see that we can see changes in the amygdala. And there's conflicting data about this as well, that the amygdala and hippocampus in general we see can be smaller in kids who've experienced different, probably what's happening and why this. Now, let's pretend that this Hpa axis is going all the time. We're getting all these chemicals, we're under threat, we're under threat, we're under threat. What we find is that this persistent activation can actually reset our homeostatic equilibrium. So if you're a kid who you've had persistent hyperarousal, you've been on edge for a long time, your noradrenergic systems, you've heard of adrenaline or noradrenaline, are on a cellular level different than someone who did not organize around that kind of environment. And then also, if we have someone who has been persistently dissociating, so in general, so we have our fight or flight system, we've got a response, you've heard a lot about that. There's this other kind of thing that happens, it's very adaptive, called dissociation, where we sort of, if there is an inescapable threat, so I cannot fight you because you're bigger than me. I cannot run away because you're faster than me. I am preparing to be injured. We can see, this is sort of like, you know, playing possum. You've heard of, this is what possums do when they're under threat, is they're like, well, at least if I lay here and maybe my heart rate goes down and my blood pressure goes down, I'm no longer pumping blood to my extremities. If I lose, maybe just if I lose an arm, I'll survive. Now, I don't think our kids are thinking these things, but what we do see, and this happens a lot in kids, that they dissociate because they tend to be smaller and slower than whoever is threatening them, that we can see persistent altered opioid and dopaminergic systems that are forever, or I don't know, semi-permanently altered. And if you have spent a lot of time learning about substance abuse, guess where all of the chemicals that people tend to abuse, guess where they work? On our noradrenergic systems, our opioid systems, and our dopamine systems. And so it's not surprising that someone who has kind of this reset equilibrium might be seeking external help to stay regulated. Okay, so backing away from kind of the sciencey part, let's talk about a little bit bigger picture about how trauma affects our ability to, or maybe not our ability, but can affect how we feel about relationships. Are they threatening or are they helpful? And so something you probably could have guessed is that experience matters. So imagine that you are a little baby and you are not born yet, you're in utero, and things are lovely there because it is warm and it's quiet and it's dark, and you hear this wonderful whoosh, 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 very rhythmic heartbeat coming from mom that is very regulating, predictable, and patterned. And then you're born, and oh man, is it tough. It's cold out there, it's bright, it's noisy, and that lovely whooshing sound I had is gone. And then also, I forgot to mention, when you're in utero, you're in like floating in water, you have this weightlessness right inside the amniotic sac, and when you're born, that is no longer there. So your proprioceptive sensory input is totally different as well. And so baby comes out and is screaming, and hopefully what happens for baby? They get bundled up. So someone's helping them get warm. You turn down the lights. And what do we automatically do when we hear baby crying? Shh. So without knowing it, you're actually reminding, and the reason it works is baby's brain organized around hearing this shh. And so, you know, we've learned from experience that going shh is regulating to a baby, but it's most likely regulating because their kind of immature neurobiology has organized around this kind of whooshing sound. And guess what else we do to babies? We rock them. And what's interesting is women tend to rock their babies at the same rate of their own resting heart rate. And I, for those of you who don't know me, which is probably all 504 of you, that I have 2 small children and have an infant, and thinking a lot about this, that it's amazing that this automatically happens. And what's really neat, so if you're wondering what are the green dots here, so when mommy is looking at the baby and regulating the baby by rocking and that it lights up a part in mom's brain that is the same as the part of the brain that is lighting up in baby's brain. We have mirror neurons. They help us relate to the people we're with. And you'll notice if someone's frowning, you automatically frown. If someone's smiling, you automatically smile. And you're like, why am I smiling? I don't know. You're smiling. Why are you smiling? I don't know. You're smiling. We have these really cool mirror neurons that help us form relationships with people. And so hopefully, baby is learning, I get my needs met and I get regulated when people are around me. And so this baby, this little green brain baby, is learning people are great. And when people are around and when they care for me, I feel regulated. Now, unfortunately, this is not the experience that every child has. And so perhaps we have a parent who has postpartum depression. And yes, they're providing the needs for the baby is still getting fed, but this kind of magical connection is not happening. Or perhaps we have a dysregulated parent who gets dysregulated by their crying infant. Let's face it, I mean, this is my life right now. It is super dysregulating when you hear a baby crying. What is magical is that you can, as an adult, become regulated while regulating the child. But if this was not a skill you learned, you're not going to be able to do it. And so you actually have this co-dysregulation that happens. And so not to say that for those of you who are raising children or interact with children, it doesn't mean that every time you have an interaction with the baby that it has to be this perfect magical moment. But what it does mean is that the repetition of these positive experiences in a relationship while the baby was getting regulated need to happen at a higher frequency than some of these kind of less desirable interactions. Okay, so sometimes, the majority of times mom is attuned, attentive, and providing the care the baby needs. Sometimes mom's distracted, maybe on the cell phone or something like that, but still providing the needs. Or maybe some days mom is, depressed and overwhelmed or dysregulated herself. But the majority of times, if this is what's happening, the schema or template that the baby will learn is that people are good and people are regulating. Now, we may have other templates that look more like this. People are dysregulating. Occasionally they're good, but that doesn't really matter much to me. That's a fluke. That actually relationships are dysregulating. And so I share all of those slides for you to understand something called the intimacy barrier. And so if you're looking at this box, we have everything in green means that you're regulated. Everything in red means you're dysregulated. And then across the bottom here, we have casual interactions to intimate interactions. And so I think most people that go into the helping profession tend to be people who kind of have this template for what relationships are. Relationships are healing, relationships are regulating. That's why, I love being around other people and why, I think that me as a person can provide some therapeutic benefit for the kids I work with because I have this template in my mind. Now let's talk about how we look at this chart a little bit more. So a casual interaction might be someone opening the door for me or looking my way or waving to me. A routine interaction might be someone comes to shake my hand and puts out their hand and I, you guys know what a handshake is, but I kind of forget with COVID, what does that look like? So I'm describing to you what a handshake is like. A personal interaction might be someone that I know giving me a hug, and then an intimate interaction may be, this could be what you might think about in a romantic relationship, but it could also be perhaps an unwanted close interaction that feels intimate just because of the context. So someone that I haven't met before, let's say, comes up to me and, I'm kind of a bubbly person, but I'm not really a touchy-feely person. And they come up to me and, oh, Megan, it's so good to meet you. And I'm in my mind kind of approaching this little dysregulated state, but the hug ends. Then what do? I actually introduce some distance between me and that person. This huggy person over here, I don't know that I want to be too close with them. That hug might happen again. I back away and increase the space between us. And now I feel I'm back in this green box and more regulated. But what happens? Let's say this stranger, oh, Megan, nice to meet you, hugs me. And then I'm ready for the hug to end and it doesn't. What do? I say, oh, okay, thank you. And I try to first use my words to end this interaction that is not welcome to me, this relational interaction. And then let's say they're still not backing off. Now I'm going to physically use my body to get away from them. So that's sort of a fleeing response. And then let's say still they're not letting me go. I'm going to hit them, right? This is just what happens because I need to get regulated again. I'm now way up here. I need to get further away from you. I need to change this intimate interaction to a personal or routine interaction. I need more space between you before I am going to feel regulated and like this sense of threat has ended. Now that makes sense to most people when I explain it that way. But what we don't think about, because we're used to this template perhaps, is we don't think about that a lot of the people that we're working with, both young people and adults, have this kind of template for what relationships are and as far as how regulating they are. And so a routine interaction, a handshake to a child that I've not met, I come up and give them, this may actually be a dysregulating gesture for me to put my hand out kind of quickly. And so they may feel dysregulated and back up and I'm kind of like, I didn't do anything. All I said was, hey, buddy, they must not like me. And then we sort of do this whole narrative and take it personally. Now, the other thing that's important is this line here, this red line, and maybe you're wondering, what is that there for? So this reflects state-dependent functioning. So everything we do is dependent on what state we're in. So let's say I am in a state of alarm. My intimacy barrier is going to shift here to the left. So personal interactions even may feel dysregulating to me. And so why is this important? Well, at least in my world, when am I interacting with people? They're in the hospital. For me, the hospital is a familiar environment. I feel comfortable here. I'm here every single morning. I know what to expect. I know what the lights mean and the sirens mean and the call pages overhead. But to the most of the people I'm interacting with, this is a new environment. So they are not in a state of calm. At best, they're in a state of alert, probably a state of alarm. And so, you know, when I'm walking in to interact with a kid, I don't need to just swing open the door and walk right in. I need to consider that, look, right here, if they're in the hospital, they're in a new environment, a crisis just happened, that even a casual interaction, me opening the door for them or glancing their way, may be an evocative cue for them to feel dysregulated, that my eye contact with them may be dysregulating. And so keep this concept in your mind, and we'll talk a little bit more about how to use this concept when you're interacting with young people and with their families. All right. So you guys know, because you all are on the front lines, a lot already about how trauma affects the psychological and developmental trajectory for kids. But let's talk a little bit also about how adverse childhood experiences can affect other outcomes. And hopefully you all have heard about the ACEs study. This was done in 1998 by Dr. Felitti, who was actually working for Kaiser Permanente out in California. So you may be more familiar with this than people on the East Coast when I moved here. But basically, he was not a psychiatrist. He was an internal medicine doctor who was helping with preventative medicine and looking at the obesity epidemic and working with patients in an obesity clinic. And what he found was that the patients would lose weight, but that they had a huge rate of people gaining the weight back. And he talked with one of his patients who said, you know, fat is being unnoticed. And I would rather be a larger body shape and get less attention than be a thinner body size and get all of this attention that I'm getting. And she revealed a sexual abuse history. And this kind of prompted him and the rest of his group to look at how do traumatic events that happen early on influence not just mental health outcomes. I think we've been thinking about mental health outcomes perhaps longer, but also physical health outcomes. And so I encourage you to look at the original article, but I'll highlight here from the results that more than half of the respondents reported at least one adverse event, or ACE, and 1/4 reported greater than 2. And these were patients who had insurance and probably were in a higher socioeconomic status category than a lot of the clients or patients that you interact with. What they also found was that in people who had experienced 4 or more categories of childhood exposure or an adverse childhood experience compared to those who had none, had a 4 to 12 increased health risk for alcoholism, drug abuse, depression, and suicide attempts, a 2 to 4 increase in smoking, poor self-rated health, greater than 50 sexual intercourse partners, and subsequent sexually transmitted disease, and around a 1.5-fold increase in physical inactivity, severe obesity, and also a graded relationship, meaning the more adverse childhood experiences you had, the more likely you were to have things like ischemic heart disease, so heart attacks, cancer, chronic lung disease, skeletal fractures, and liver disease. And this may not seem shocking to you. You likely know this information, but at the time, this was a landmark study to get people thinking about, wait, what happened to you early? You know, I'm interviewing this 50-year-old patient. Do I really need to talk about what happened to you from age 0 to 18 months? Yeah. And even I'll tell you, in childhood, in my child psychiatry fellowship, oftentimes I had this kind of idea of like, oh, you know, the kids don't remember that. We don't really need to do a lot of work around that. Or families would not even think to mention what happened to the kid before they were adopted, because, oh, well, they were adopted around age 2. But what we know is that these early experiences matter, and they matter for mental health reasons, but also for physical health reasons. All right. And so when I'm talking about the psychological impacts of trauma, you guys know these. You see all of these labels that come along to describe the symptoms that people experience as a result of their early adverse experiences. So I am sure if you've ever read a medical record of a patient with the kind of history like Kay that we presented at the beginning, and I pared it down. Actually, this patient probably had 5 or 6 diagnoses on her chart. But it's interesting, in mental health, we accept that it's reasonable that this kid has 6 different diagnoses. Oh yes, to explain their symptoms, they have ADHD, generalized anxiety disorder, ODD, major depressive disorder, PTSD. No other area of medicine would we accept that the reason for your shortness of breath is 7 diagnoses. But we somehow think that that's okay, and that's the best explanation for what's happening with these kids. But what if, instead of giving all of these labels to try to describe the effects that we're seeing now based on what happened, in their development to disrupt their development, what if instead of all of these labels, we had a picture of understanding of what's happening in these patients' brains that explains their symptoms in a better way? And so I'm going to show you this report. I don't expect you to be masters at reading this, but with the NMT model that you can, I'll talk a little bit more about the assessment tool that you can use if you decide to look more into the NMT training. But what I'm going to focus on, remember the upside down triangle, I told you we'd come back to it, to look at how that upside down triangle, if we talked about these 4 kind of big categories. But I'm going to break down each category even more. So we have our brainstem, these 6 boxes. You can see they're pink, corresponding with the pink brainstem over here. That your brainstem is also in charge of suck, swallow, gag reflex, your autonomic regulation, which that means, my heart rate should go up when I am trying to run. It should go down when I'm trying to sleep. You can see the yellow part here corresponds with sleep and fine motor skills, our ability to gain or lose weight. And then up here, I won't go through all of the domains, but you can see, I want you to understand what this picture represents. And then I'm going to show you a picture of a metric report that looks similar to this one for the patient that we talked about, Kay. And so you can see, if I'm looking at this functional brain map, you'll have to trust me that red means immature, green means more mature and developed, that for this patient, that they were 9 years old. So for an 8 to 10-year-old, these lower parts of the brain are pretty much should be fully mature. But look at this child with early trauma. These lower parts of the brain were not getting the correct information at the right time when that part of the brain was developing. And so these parts of the brain subsequently are underdeveloped. And so you can see, when I say a picture, not a label, here's the picture of what's happening with this kid. It's not that this kid has ADHD, PTSD, ODD, MDD. It's that they have developmental deficits due to the fact that they were experiencing early adversity, neglect, domestic violence exposure, that their brain organized around the environment that they were in and did not develop in these other areas in a typical way. And so those parts of their brain did not mature. And remember, I mentioned you develop bottom up. Until these parts of the brain are, we help get them back online, help build maturity there. We cannot expect these higher parts of the brain to catch up. So let's talk, and then I like to highlight here these lower parts of the brain. So when we're thinking about the first patient that we talked about, Kay, the first 18 months of her life, this is the part of the brain that's really developed or developing during that time and needs a lot of input to develop. That we can see deficits in these areas when kids are in a neglectful environment at that age. And so they might have trouble with sleep. She sure did, right? Might have trouble with her fine motor skills, with feeding and appetite. And I highlighted all of these because these are symptoms that bring kids to their pediatrician, not to their mental health provider. And so I encourage you to have in the back of your mind, if you're taking care of a kid or interacting with a young person who has, sleep problems, obesity or failure to thrive, they have reflux, they have a tremor or a tic, they have maybe a tic in their eye, or their eye movements are abnormal. Maybe again, it's not that they have 7 different medical diagnoses, but maybe it's a result of underdevelopment due to their early neglect experiences. All right, so let's bring this back to Kay. And again, I'm not expecting you to remember all of these things, but when you look at her picture, and remember, she was only in a neglectful environment from age 0 to 18 months old. And you can see, so this is what she should look like. These bottom parts of her brain should be this brighter green colored, representing being fully matured. And she should not have any red. And what you can see is in this column here, which this column has a lot to do with your ability to stay regulated, is very underdeveloped. It probably looks more like an 18-month-old to maybe 2 or 3-year-old. And then this row here, when you see kids with problems with this grouping of functional deficits, that they have trouble forming relationships and attachments in a healthy and regulating way. Now, what's so interesting about Kay is, look here, her cortex, these top 2 rows, they look pretty similar to kids her age. And why is this important? Well, how often have you said, oh, you know, she's such a smart girl, and, you know, when she chooses to, she can do her math homework, and when she chooses to, she can have a good day, but she chose to have a bad day. Tell me one time you woke up in the morning and you were like, yes, I am choosing today to have a bad day. It just doesn't happen, right? We don't do that. And so why would a child say, yes, today's the day, I'm going to manipulate everyone around me and have a terrible day? It doesn't happen. What's happening to this kid is her ability to stay regulated is immature. And so when she feels dysregulated, often by people, because her ability to form relationships and attachments is underdeveloped, she gets dysregulated by people. Guess when that happens? At school every day for this child. She looks like an 18-month-old to 2 or 3-year-old. And so she has these tantrums that look very young and immature for her. And then when she's calm and gets back in line, she looks very mature and her chronological age. So a picture, not a label. This describes this child way more accurately than saying that she has ADHD, you know, some primary sleep problem. She has bipolar disorder, which if you see bipolar disorder on a chart for a 7.5-year-old, you should automatically scratch your head. It does happen, but it is very uncommon. All right, so now that we talked about what happens, let's talk about what are some tools you can use for further assessing and understanding these young people. So I did mention the metric reports. I'm not holding the expectation that when you leave here, all of you will complete the NMT training. What I am wanting you to know is that this tool is out there, and it's an online web-based assessment tool that you can use. You input the history of the patient, and then the output looks something like this, where you look at their developmental history from intrauterine to prenatal, infancy, early childhood, and childhood, youth, and then there is an adult category also. And this kind of tracks what was their level of adversity and what was their relational health, because we do know that relationships form buffers for adversity. And so it helps you kind of know when in their life were they at the highest developmental risk. So looking at Kay, for example, she would be at a very high risk for these beginning parts. This is a metric for a different patient, but she would be at high risk in the beginning of her life and then move down into this lower developmental risk. And then, you know, I showed you the example of the output looking at their current level of functioning. And what's really cool about these reports is that it breaks it down into 4 categories, and including sensory integration, self-regulation, relational, and cognitive. And again, the 4 parts of the brain, they correspond with those different brain areas. And then it's neat, it gives you this treatment planning guide. And what we know is that if you structure the timing of the interventions based on that bottom-up idea, meaning, and remember the pink box was the brainstem, the yellow was midbrain, green was limbic system, blue was cortex. If you start with interventions that help support the maturation of the lower parts of your brain, if you start with those, you're going to have much better success with some of the kind of cognitive-based treatment. So what might that look like? And I know this is small, so I just want to read this box here to give you an idea of some different types of treatment that help with sensory integration and help with the maturation of your brainstem and midbrain. So that could be things like healing touch or therapeutic massage, yoga, rocking, swinging, therapeutic drumming, swimming, animal-assisted therapy, which we'll talk more about later, martial arts. And then we move into music and movement, occupational therapy, running, walking, exercise. So all of these things that we sort of recommended before as like, take your medication, go to therapy, and if you have time, do these other things, that these other things actually are the medicine. And so I will prescribe to patients, if you want to take your medication 3 times a day, that's great. I support that. And I need you 3 times a day in small bursts to and it sounds kind of goofy. People think I'm goofy sometimes. I need you and your child to dance for 2 to 3 minutes, before you brush your teeth or while you're brushing your teeth. And then later in the day, I want you to do it again around lunchtime. That these are actually very regulating activities to help remember we talked about top-down regulation using your cortex to kind of regulate the lower parts of your brain. These structured activities will actually keep the lower parts of your brain regulated, so you have the chance of improving your overall regulation, both now, but also in the future, because your brain is going to be learning these things. All right. So other tools when you're assessing, so we're going back to this chart, keeping this in mind when you are working with patients or with kids and with their families, that you must, one, stay regulated yourself, but you must help them become regulated before you can do any cognitive work. And I think I talked about that enough before, but I wanted to come back to this also to consider. So I don't know if you've had this experience. I know I have it a lot, where I'm meeting with families, I go through this whole plan, and then like an hour later, I'm getting paged, are you going to come meet with this family? They say they haven't met with you yet. And I used to get really frustrated by that. Like, really? I spent all this time, you didn't get anything from that. What am I doing wrong? But then it occurred to me that I'm probably working with clients when they're here. And so they might, when they see me again, they might remember, and I say, hey, do you remember that question I asked you earlier? I sure don't. I did not do a good job helping them get regulated before talking with them. Now, what does this mean? This doesn't necessarily mean you got to walk in and do a mindfulness activity, or, okay, now we're going to listen to a song together. It may mean that. In fact, there's kids that I work with that I know their favorite artist, and I just walk in with my phone and I'm playing the music, and we just kind of sit and maybe watch the video together, depending on if it's an appropriate video or not, or we might just listen to the music together and do some kind of regulating, and it's relational activity before we get started talking about anything. And you may say to me, no, Megan, this isn't right. I calm people down with words all the time. And I would argue with you, perhaps, you calm people down all the time while you're talking to them, but it is probably not your words that are helping them stay regulated. It's probably things you're doing with your body. So if you're standing and you're talking to a kid and you come down to their level, you're making yourself look less threatening. Limbic system goes, oh, okay, maybe it's not dangerous. You're also talking in a rhythmic way. Okay, Johnny, I'm here. Let's say someone comes in after a trauma. All right, I'm here for you. My name is Megan. I'm going to be with you every step of the way. I am here for you. I'm talking in a very rhythmic and patterned and predictable way. I'm using a soft voice. I'm using a calming voice. I'm not using a whole lot of, the way I normally talk, a whole lot of, modulation in my voice. I'm staying very patterned and rhythmic. That is probably what is regulating to that person more than the content of what I said. And think back in your own life where you feel like you really did help someone by talking to them. If you probably ask them, what did I say? They don't remember. Maya Angelou actually says that, people will not remember what you said, but they will remember how you made them feel. I'm paraphrasing, right? She said it much more eloquently. Okay, so this is a tool for assessing people that you're working with, but also for helping provide providing treatment. Now let's go back to the intimacy barrier. I talked about that we would use this in order to think about ways and strategies for interacting with people to help them stay regulated. Okay. And Dr. Perry made this great, it's called the NM 10 tip series. I made a slide based on this document that he has about how do we manage relational sensitivity. We're going to go through the top 10. So the first thing is watch your proximity. So remember we looked at that graphic where along the bottom we have the range from casual to intimate interactions. I can help people move back up to the left of that box just by moving away from them, by going from a personal interaction to more of a routine or casual interaction. And you guys know this, you've done this, I'm sure, without thinking it, and you notice that people get more regulated when you back up. Or when, you know, there's a crisis and a bunch of people come running, what do? All right, guys, please step away. We know this. This is one that may be less intuitive. So being present, so kind of, and being patient, you know, all right, buddy, you know, when you're ready to talk, I'm here. But another thing that I don't often think about is being parallel. So, you know, if I'm talking to you directly, face on, that's actually kind of a threatening posture, right? If you're going to attack someone, you're going to be facing them head on. Now, if I'm standing with my body kind of perpendicular to you, this is not a stance that says to your limbic system, hey, I'm about to come eat you if I'm a lion, right? I'm facing this direction. So when I enter a room, and I'm really anytime, but particularly if I'm expecting the person I'm talking to be dysregulated, I'm going to be standing kind of, I'm going to be looking at them perhaps, but sometimes not. Sometimes I'm just looking kind of the same way that they're looking. And that's what I mean by being parallel to them. The other thing I'll say is to let them come to you, right? I don't know their relational sensitivity. I don't know their template. And also remember that intimacy barrier shifts depending on their state dependent or their state functioning, right? Whatever mental state they're in. So two things, I can help them get regulated. That's going to allow them to be able to interact with me and be less tuned up to our interaction. But also, because I don't know, is this too close? Is this too close? Is this too close? If I let them come to me, I'm letting them choose what is the right amount of space right now that we can still interact and you can stay regulated. This is really important too when you think about kids with reactive attachment disorder, or now called disinhibited social engagement disorder. Oh my gosh, this is recorded. Please look at it. It's DSED. It's new in the DSM-5. I grew up on the DSM-4, so I mix up the letters all the time. But when we have a kid who's so disinhibited that maybe they just hop in your lap when you just met them, that wouldn't be an inappropriate interaction. So that's always really confusing. So I'll have parents, foster families, when I'm working with them and explaining this, they're like, no, you know, Kate likes to be close. She's always jumping in my lap. And then, you know, the other day she was crying, and so I went and picked her up and put her on my lap, and she said, F you, and she punched me in the face. I just don't understand. Well, the day that she was bebopping into my lap, she picked how close she wanted to be to me. But the day I went and picked her up, when, by the way, she was already dysregulated, I'm trying to comfort her because I'm a big green brain person, thinking like, oh, I'm going to make you feel better, like, because relationships are helpful and regulating. They are helpful and they are regulating, but not for everyone at all the time. So letting them come to you helps manage that relational sensitivity. I think you guys get the point. I can't see you nodding, but I think you guys got it. So I mentioned, don't take it personally. Easy to say, harder to do. Give them elements of control. So I will often say, all right, you know, I'm going to come talk with you. Where in your room should I sit? You know, what feels better for you? Is it better if I have the lights on or have them off? Do you want a pillow kind of in your lap between us? Do you want the desk in between us? Do you not like that? Get kind of letting them set how we meet. And this is easy to do. You don't have to be in an office. I do this in the hallway. Where should I stand? Where should I sit? Giving them control. And this is hard for me because I like to move, but I have to remember that if I'm working with someone who perhaps they have an underdeveloped cortex and they're really trying to make a decision, then I need to give them time. And if I do have to touch the person, to give them a warning. So, hey, I'm going to put my
I need to take your blood pressure. Where should I need to put my hand either on your shoulder or on your arm? Where's the best place? And kind of let them guide me, and then also just announce I'm about to touch you. That gives their limbic system a little bit of warning. Oh, something's coming. So they're not just reactive to it. This is my favorite, number 8. So understanding relational interactions are their evocative cues. What does that mean? So if you think about someone who is a veteran who has returned from a combat zone, and you can easily understand that the sound of gunfire would be triggering for them, would be an evocative cue. So I wouldn't start therapy by firing off a gun in my office, right? I would not expect to make much progress with that. That's very obvious. What is less obvious is that I am the gunshot, okay? Not meaning to be, it's no fault of mine, but scary things have happened to this person I'm working with in the context of a relationship. Relationships are scary, and you are trying to start one with me. Like, you are firing a gunshot, and then you want me to talk about, what's your mood like today? Do you feel safe going home? Well, what happened to you last week in this? I heard a report that, your mother hit you, and I just shot a gunshot off right before asking you these types of questions. Do I think that I'm going to get a very regulated kid? Do I think I'm going to get a kid who can access their cortex to even answer me in a meaningful way? Absolutely not. So now, unlike the gunshot example, you can clearly not bring a gun to your office. I recommend you do not bring a gun to your office, or fire anything loud before you're working with patients, right? I mean, that's obvious, but I cannot prevent that I have to be in the room with you or be interacting with you in order to learn about you. But what I can do is remember that I am going to be dysregulating until I help this kid or person become regulated. And so that might be all of the things we talked about, it could be just pausing before I get started, like giving them a moment to have heard the gunshot, realize I'm okay. I see this new stranger, had a minute to go, oh, this is just Megan. It's not the scary thing that happened to me earlier. Just pausing sometimes and recognizing that I am the evocative cue. All right, the other tricky thing is, while I'm saying maybe back up, also remembering that these young people are really sensitized to abandonment. And so if I am going to leave, hey buddy, it looks like you're pretty agitated right now. I'm wondering if it'll be easier for you to calm down if I'm out in the hallway. So I'm thinking that I'm going to back out into the hallway now. So I'm going to, I'm just going to take about another step back, and now I'm going to walk out the door. So I'm kind of narrating a little bit. And again, I know I told you that words may not matter when someone's dysregulated, but I'm talking kind of a predictable, rhythmic kind of way. And I'm also announcing that. Super important. So, and we're going to talk a little bit about social contagion, but that you must regulate yourself before you can expect to regulate anyone else. And we will come back to that. All right. So now, other treatment options. Let's talk about K. Here's where we started. Now, synthesizing all of the information that I've shared so far. Look at all these other things we can do for her. I feel so much more adequate as a care provider. So for her, remember we talked about that she has a lot of relational sensitivity and self-regulation problems. Number one, psychoeducation. So talking to her care providers, talking to her legal team about all of the concepts that I just shared with you, that, yes, she looks like a typical kid when she's regulated, but when she's dysregulated, it's not her fault. She's not choosing to do this. How do we help her stay regulated? Maybe we can decrease her relational triggers. Perhaps she needs a smaller classroom. Perhaps she needs time where she's in a classroom setting, but she gets to pick what happens. So maybe that's in an after-school care environment where she gets to pick where she's playing and also how close she is to the other kids. Maybe she's not really ready to be in relational interactions with people, but maybe she can have animal-assisted therapy where her interactions are with animals who probably have not hurt her and she has not had a negative experience with. Horses are a great example of that. Most of the kids I work with have not had a negative experience with a horse, but they can kind of learn how to be with another living, responsive animal like a horse and stay regulated at the same time, and then eventually generalize that skill. So we talked about acknowledging and respecting the intimacy barrier, also using rewards for developmentally possible expectations. And what I mean by this is I may still, well, let me read the next bullet, which is maintain expectations, but I modify my response to unmet expectations. And what I mean by that is I may still expect, okay, that you're going to come sit at the table with family for dinner, but when you are not able to do that, that you, that maybe I'm not punishing you or raising my voice. I'm just saying, oh, okay, like you're not ready to do that, and that's okay. All right. Other things that could be suggestive for her are more geared towards helping with her self-regulation. So that might be looking at occupational therapy, which can help with sensory regulatory activities, working on her sleep hygiene, considering other sensory challenges that she may have. This part I love. So let's skip down to here. So we're getting a little bit close to time. I want to leave enough time for questions. Things that your brainstem and midbrain love are patterned, predictable, parallel, and relational activities. So that could be music, that could be dancing, that could be coloring side by side with another kid. I do this all the time in the Children's Hospital. It's super easy to walk around with some paper and a bag of crayons. Hey, we're just going to sit and color. I'm not going to ask you much, but we're just going to sit and color. And I'm talking 5 minutes. And then I'm going to ask you how you're doing. Throwing a ball back and forth is actually a very great rhythmic, relational, and parallel activity to do. So if you're brainstorming, I want to give you the skills so that you can creatively problem solve for yourself. So thinking about if it's parallel, it's rhythmic, it's patterned, and in a relationship, it is most likely going to be regulating for everyone. And what's interesting, so we're working with families who did not learn these things, and then we want them to teach them to their kids. So, hey, I know you didn't grow up learning Mandarin, but your child really needs to learn Mandarin. It doesn't work, right? But when we give the parents these things to do, hey, oh guys, I want you to color 3 times a day, side by side. What we find is that their brain maps actually show improvement in the same areas as their child. And what's interesting, so here you can just see mom and kid both have the same areas that showed functional deficits. And what we see is as we provide treatment for these domains, that the parents also benefit. So the great news is while you're providing treatment for the child, you're also providing treatment for the family. And I can tell you for sure, no medication that I prescribe also treats the family. So all of these other things give me much more hope than just medication. So going to our last objective, I just want to talk briefly about how important relationships are for healing. And so to just think about that, 50 minutes of therapy per week is very important. Please have the kids continue that or adults continue that. But also think about who else is in their tribe. So our brains actually evolved in a tribe where we had 30, 40 family members, not, small 2 or 3 family members. That we need to be thinking about who else in their community can provide this consistent, positive relational interaction. Maybe it's a religious organization. Maybe it's their neighborhood community center. Maybe it's big brother, big sister programs. But thinking beyond just what's happening in kind of this small relationship, either in the care provider and client interaction or the family interaction, but kind of thinking about their entire network. And since we're thinking about relationships, I'm just putting this back out here that a dysregulated adult can never regulate a dysregulated child, and a dysregulated adult will always dysregulate a child who's regulated. So if I walk in at home and my 2-year-old's having a lovely day, but I'm in a hurry and I'm like, hey buddy, you put your cup on the table, guess what happens? His little limbic system goes, threat, and we have a tantrum. But if I pause before I get out of the car and think about, can't wait to see my kids and how great this is going to be when I get home, and kind of regulate myself, much different interaction. All right, and then just to summarize in Dr. Perry's words, that when we're creating an individualized plan of therapeutic activities, again, pick activities that are relevant, relational, repetitive, and rewarding. And then later, After you do these kind of rhythmic and repetitive activities, then maybe you add trauma-focused cognitive behavioral therapy or parent-child interactive therapy. You still use those, but maybe you spend the first couple months that their therapy is actually just, we're coming in and coloring every day, or we're making slime, or we're doing yoga together, or we're doing therapeutic drumming. This is what we did at the Center for Child Protection. And then later, when you can stay regulated, we can do some of these more conventional individual therapies. All right, to close it back out, go back to the question I asked you at the beginning. Have in your mind, what did you say the answer was? And who is likely to have better outcomes with treatment? And this may not be surprising to you now, but to me, I mean, as long as I can remember, including in training, I would have thought if you had 10 and a half years of chaotic living environment versus 1.5, your outcome would be worse. But it is the timing of the traumatic experiences that matter. I mean, it all matters, but that the timing is very, very important. And so we want to be asking, what happened to you and when did it happen to you? And think about what part of your brain or what skills were you supposed to be developing at that time. And the earlier it was, the more likely it was skills in self-regulation and sensory integration, the more likely you are to have deficits in that area. Now we cover it all up because you get to school age and your cortex is learning all these things in school. We kind of forget about these earlier skills that we just assume you should have by now. But we need to keep in mind that a lot of the young people that we're working with miss the opportunity to gain those skills. And so not to say that if you have a child like Kay, that there's no hope. We just talked about all of the hope there is when we pick the right interventions at the right time for the right amount of repetition and consistency for the patients, that they really can have better outcomes with treatment. And so to inspire you a little bit, that hopefully we just added all these tools to your toolbox. So all of the things you're already doing for these young people, that if we start adding targeted therapies that help with self-regulation, that help kind of repair what was missed when they were younger in those critical years. And this is even if you're interacting with adults, these are still really important things to go back and relearn, that if we structure it in the right way, that we're going to have a lot better chance for helping our children and helping their families. And so I'll leave you with, if you want to learn more, please check out childtrauma.org to look at the Child Trauma Academy. And also just to put one more plug for Dr. Perry and the Child Trauma Academy, as they've just been instrumental in helping me kind of grow my practice and way of helping these kids. And then you have other references that I use throughout the talk.